Again, I would like to thank Kara, Renee, and the rest of the Prostate Conditions Education Council team for having me back for another year to provide another prostate cancer webinar for PCEC. It is definitely an honor as PCEC continues to be a national leader in increasing awareness and education on prostate cancer, current treatments, and men's health issues. PCEC is an amazing resource for men and those that care for them. So today, I'm going to be giving a talk on the evolving role of hormone therapy in the management of prostate cancer, also known as androgen deprivation therapy. Over the last 10 years, there really has been an explosion in the number of treatment options we have now in the management of advanced prostate cancer. I'm excited to review not only some of the natural history in the treatment of advanced disease, but also some of the new treatments we now have available in terms of androgen deprivation therapy. I'm a private practice urologist at Carnegie Urology Center in Nebraska. I'm also host of the Prostate Health Podcast, a podcast where I'm fortunate to have the opportunity to routinely chat with experts, innovators, and leaders in the field of urology, which for me has helped keep me up to speed on a lot of the latest technology and treatment in managing prostate conditions. There has certainly been a significant evolution in the way we manage prostate cancer. So from a historical perspective, the concept of androgen ablation to control prostate disease goes back to 1786 when the surgeon John Hunter described seasonal variations in the size of the testicles and prostate gland in animals. He later concluded, on the basis of the effects of castration, that there was a direct connection between the testes and secondary sex organs. The first radical prostatectomy was performed in 1904 by Hugh Hampton Young at Johns Hopkins in Baltimore. Now, one of the major breakthroughs in the treatment for advanced prostate cancer was by Charles Huggins in 1938 for his discoveries concerning hormonal treatment of prostate cancer, and was ultimately awarded the Nobel Prize for his work in 1966. He discovered that if the production of male sex hormones is prevented through surgical castration, or if female sex hormone is added, the cancer could be suppressed. Fast forward to the 1970s and the work of Andrew Shalley from New Orleans, he won a Nobel Prize for his work in studying the messengers from the pituitary, particularly the LHRH pathways. In the 1980s, long-acting synthetic LHRH agonists, such as Lupron, came onto the scene as an alternative to surgical castration. Then really over the last 10 years, there's been an explosion of new therapies available. LHRH therapies are not going away. They are the standard of care, and now we're building on those. We're adding antiandrogens, we're adding chemotherapy, along with several new anti-androgen drugs, vaccines, and new biomarkers, which continue to revolutionize the way we're able to help men with prostate cancer. So this graph does a nice job of mapping out the natural history of prostate cancer, with the light line reflecting prostate cancer volume and activity. So after the first little blip, we see the prostate cancer responding nicely following surgery and radiation therapy. Now, some will unfortunately have a prostate cancer recurrence following initial therapy, and this is where you'll see a surge in prostate cancer activity. This is where we can implement hormonal therapy, also known as androgen deprivation therapy, where we can drop the testosterone to very low or castrate levels defined as testosterone levels less than 50, using medications such as LHRH agonists. For many men, this therapy will prove to be effective for many years, and this is where we are still in what we call the hormone-sensitive phase. With the androgen deprivation therapy, we are suppressing the prostate cancer activity to very low levels. But eventually, the prostate cancer cells can get smarter and become what we call resistant to the low levels of testosterone, called castrate-resistant prostate cancer, where the prostate cancer cells become smarter and figure out a way to thrive in the absence of testosterone. And we see this curve start rising upward again as the prostate cancer starts to become more active. And when that happens, we have additional therapies we can implement for these men. Early on, men have no symptoms, but with time, symptoms can develop. Then we can also start visualizing the cancer on X-ray, in the bones, for example. Here's just another graphic representation outlining the multitude of options we have available. Some available for localized or disease which is contained within the prostate versus treatments for advanced metastatic prostate cancer. Some treatments available only when the disease becomes resistant to castration. Some available for both castrate sensitive and castrate resistant disease. The body naturally produces hormones called androgens, primarily testosterone. Androgens are needed for the prostate to function normally. However, when androgens attach to androgen receptors, they can help prostate cancer cells grow. We'll discuss more about androgens here in just a moment. Androgens help prostate cancer cells grow. The main androgens in the body are testosterone and dihydrotestosterone, or DHT. Most androgens are made by the testicles, about 95%. But the adrenal glands, the glands that sit above your kidneys, as well as the prostate cancer cells themselves, can also make androgens. Activation of the androgen receptor signaling pathway by androgens is critical for prostate tumor growth and disease progression. So by reducing the availability of testosterone to bind and activate the androgen receptor by either lowering testosterone levels or blocking the receptor directly can result in decreased tumor cell proliferation. You may hear of this therapy referred to either hormone therapy or androgen deprivation therapy, or ADT. It involves depriving prostate cancer cells of their fuel, or androgens, by reducing the levels of male hormones to very low levels, and can be effective for many years. Hormonal therapy is the foundation for advanced prostate cancer, again because prostate cancer is primarily androgen dependent. So who is a candidate for androgen deprivation therapy? Some of the more common uses for ADT include initiating therapy at the time of diagnosis of metastatic prostate cancer, and now there is some evidence to suggest that there may be some additional benefit to adding in some chemotherapy alongside of hormonal therapy. It can be used with radiation therapy for localized prostate cancer, typically anywhere for 6 months to 2 years duration, and for treatment failure of localized disease, inappropriate candidates when a rising PSA is noted after initial treatment. So some of the various options for androgen deprivation therapy include surgical castration, also known as an orchiectomy, and removing the testes, which is an irreversible form of ADT and is not often utilized. Estrogen therapy is also not utilized anymore for prostate cancer. With the mainstay of ADT, which has involved the use of LHRH agonists, these are injections which can be administered and can block testosterone production by the testicles without having to remove the testicles. These come in 1, 3, 4, and 6-month formulations. Following the initial administration of the agents, you can get an initial testosterone spike or flare. Where this is important to be aware of is men who already have cancer in the bones. That initial flare can cause problems, including possible pain, so they can be given anti-androgens prior to the initial shot to help block that flare. There are LHRH antagonists, such as degarelix, that also block testosterone production. But you don't get that initial flare in testosterone because they bind to the LHRH receptors and don't cause an initial release of LH or FSH. But one downside is that there are not longer formulations available and require monthly injections. Now, with that being said, there is a new available daily oral formulation with relugolix. And lastly, we now have several newer agents available for advanced prostate cancer that work a bit differently in manipulating testosterone, but you still need to be maintained on traditional androgen deprivation therapy for them to work, and we'll cover those in a bit. A few of the goals of therapy to include achieving and maintaining a consistent low testosterone level with no escapes or microsurges. Typically, the goal is to reduce the testosterone level down to a castrate level. A serum testosterone level of less than 20 nanograms per deciliter is considered the target for castration, whether surgical or chemical. This is a change from the previous definition of a castrate level of less than 50 nanograms per deciliter, which was based on old assay methods. Ideally, rapid onset of suppression is preferred, and blocking or blunting surges if relevant. There isn't always a one-size-fits-all option, and treatment can be tailored to meet an individual's lifestyle and personal preferences. Cost is certainly a consideration, and most importantly, would be looking to minimize side effects as best as possible while extending survival outcome. Some of the side effects of hormonal therapy listed here, including but not limited to hot flashes, which may potentially get better or go away with time, loss of sexual desire or drive, fatigue, osteoporosis, loss of muscle mass, diabetes, cardiovascular disease, depression, and memory issues. One of the primary side effects of hormonal therapy is a lack of sexual desire. Definitely speak with your provider if you are affected. Counseling and psychological support can be valuable. There may also be some effects on erectile function, which may benefit from medication. And some men who are really not tolerating some of these side effects could consider more of an intermittent approach, where they will go off therapy for a period of time and then undergo another injection intermittently, likely when their PSA starts rising up again. More than 75% of men on hormonal therapy experience hot flashes, which can certainly affect quality of life. Counseling, psychological support, and behavioral therapies can potentially reduce the impact of hot flashes. Medications can also potentially help. Some medications that have been used include progestins, such as Megace, antidepressants, such as sertraline and venlafaxine, and gabapentin, which is an anticonvulsant, and all have been utilized with varied success. While not approved for treating hot flashes, the use of oxybutynin, which is a medication for overactive bladder, has been found to reduce the frequency of hot flashes. And lastly, discontinuation of therapy if still having bothersome hot flashes not controlled, essentially going to more of an intermittent AEDT approach. Men on hormonal therapy need to be closely monitored, and we'll be monitoring their PSA closely, as well as follow-up imaging studies where indicated. Maintaining bone health is very important. One of the possible side effects of ADT includes bone loss. It is typical to obtain a baseline bone density scan and then periodically recheck that, as well as supplemental calcium and vitamin D to achieve adequate levels, including 1,200 milligrams of daily calcium and 600 to 1,000 international units of vitamin D. It is also very important to keep a close follow-up with the primary care provider, who can also help in closely monitoring the patient as well, including monitoring blood pressure for diabetes, stroke, and heart disease. While being maintained on hormonal therapy, in addition to bone health, it is also important to maintain a healthy weight, as well as regular weight-bearing exercise. You also want to make sure you are keeping up with a healthy diet. We typically say what is good for their heart is good for the prostate. Hormonal therapy can also increase the risk for cardiovascular disease, particularly those with pre-existing cardiac risk factors or a family history of cardiovascular disease. At baseline, the risk of cardiovascular events, including MI, stroke, or cardiovascular death in prostate cancer patients is greater than 2% per year. That doubles to greater than 4% in prostate cancer patients on androgen deprivation therapy. And the risk is thought to be even more significant for those on hormonal therapy for more than 2 years. Again, the mainstay of ADT has involved the use of LHRH agonists, which avoided some of the side effects of estrogens and avoiding surgical castration with orchiectomy. These are injections which can be administered and can block testosterone production by the testicles without having to remove the testicles. These come in 1, 3, 4, and 6-month formulations. Following the initial administration of the agents, you can get an initial testosterone spike or a flare. How LHRH agonists work is that they stimulate LHRH receptors in the pituitary gland. This stimulation produces an initial increase in FSH and LH, which can cause an initial increase in testosterone, also known as the testosterone flare. Further stimulation of the LHRH receptor ultimately leads to suppression of FSH and LH, resulting in a decrease in testosterone. It may take around 30 days for testosterone to reach castrate levels. One potential downside of LHRH agonists used on their own is the potential for microsurges in LH and testosterone with repeat injections. Also, FSH suppression may not be maintained long term. Then there are LHRH antagonists that also block testosterone production, but you don't get that initial flare in testosterone because they bind to the LHRH receptors and don't cause an initial release of LH or FSH. But one downside is that there are not longer formulations available and require monthly injections. With that being said, again, there's a new available daily oral formulation now. One nice feature is that the injectable form can reach a castrate level of testosterone in about 3 days. So in my practice, I'll often start patients off initially with an LHRH antagonist injection, then transition them over to a LHRH agonist in 1 month after their initial injection. Additional features include no microsurges of testosterone, as well as prolonged suppression of FSH, LH, and testosterone. Antiandrogens inhibit the androgen receptor, so prevent the binding of DHT and testosterone to the androgen receptor. The first and second generation antiandrogens were developed primarily for use in combination with LHRH agonists to provide combined androgen blockade. The third generation of antiandrogens are a bit more sophisticated in that they inhibit multiple steps in the androgen receptor signaling pathway and are considered more effective because of a higher affinity for the androgen receptor, secondary to the differences in mechanism of action. One common use for the first and second generation antiandrogens has been to start an antiandrogen prior to starting an LHRH agonist to help avoid a testosterone flare. Monotherapy with antiandrogens alone are less effective than medical or surgical castration. Let's take a moment to review the potential progression of prostate cancer. For newly diagnosed prostate cancer localized to the gland, treatment options include surgery, radiation therapy, or active surveillance. A rise in the blood level of PSA, or prostate-specific antigen, in prostate cancer patients after treatment with surgery or radiation is typically called a biochemical recurrence. Biochemical recurrence may occur in patients who do not even have symptoms. It may mean that the cancer has come back. Studies have reported that 20 to 40% of men experience a biochemical recurrence within 10 years of definitive prostate cancer treatment. For patients who experience biochemical recurrence after surgery or radiation, one of the options is hormonal therapy or androgen deprivation therapy, or ADT. When the cancer is responding to therapy, the cancer is classified as hormone-sensitive prostate cancer. Prostate cancer that keeps growing, even when the amount of testosterone in the body is reduced to castrate levels, is called castrate-resistant prostate cancer. If we are not seeing the cancer detected yet on any scans yet, it is called non-metastatic castrate-resistant prostate cancer. Approximately 33% of patients with non-metastatic castrate-resistant prostate cancer develop metastasis within 2 years of diagnosis. So in detecting advancing prostate cancer in men on hormonal therapy, we will first start to see the PSA rising. We'll want to check the testosterone level to verify that we are getting the testosterone levels below 20. We'll also get scans to see if we are able to visualize the cancer. Some of the more common initial scans, including a bone scan, other imaging options, including a PET scan that may be able to detect cancer not visualized with more common imaging techniques. We also look at the PSA doubling time, which calculates how rapidly that PSA number is going up. Androgen deprivation therapy is highly effective and can induce a PSA decline in more than 90% of patients. However, given sufficient time, some patients with hormone-sensitive non-metastatic disease will progress to castrate-resistant metastatic disease despite ADT. It is estimated that 10 to 20% of patients diagnosed with prostate cancer will go on to develop castration-resistant prostate cancer within 5 years of follow-up. Castration-resistant prostate cancer, again, where the prostate cancer gets smart and figures out how to grow and thrive despite testosterone suppression, where we see a rise in PSA despite hormonal therapy. Either non-metastatic, where no visible spots of cancer throughout the body are showing up, or metastatic. This here is a bone scan where we unfortunately see spots of metastatic prostate cancer throughout the skeleton. While there is currently no cure for metastatic prostate cancer, over the last 10 years, we have fortunately had an increase in the arsenal of available treatments in treating advanced prostate cancer. We have androgen pathway targeting, radiopharmaceuticals, immunotherapy, chemotherapy, and DNA repair agents. Again, as we are getting into utilizing some of these newer therapies, it is important that we still maintain a castrate level of testosterone therapy, so men will still need to stay on ADT. When looking at the goals of therapy in castrate-resistant prostate cancer, the first is to prolong life, and then to prevent pain and complications, while at the same time preserving quality of life and performance status. One of the newer agents utilize androgen pathway targeting, and we'll be wrapping up the webinar with androgen pathway inhibitors, or APIs. APIs can further reduce the activation of the androgen receptor, and we'll review a few of the available agents here in some of the upcoming slides. All APIs require continued concurrent hormonal therapy, or ADT. Some of the APIs include abiraterone, enzalutamide, apalutamide, and darolutamide. Today we'll be honing in on abiraterone and enzalutamide. So abiraterone acetate is the first API we'll discuss. Abiraterone inhibits the enzyme CYP17 that is required for androgen biosynthesis. There are multiple sources of androgen, including the testes and adrenal glands. However, in metastatic prostate cancer, the tumor itself can be an additional source of androgen production. So this agent inhibits androgen production at 3 sources: the testes, the adrenal glands, and the prostate tumor itself. It is approved for metastatic castrate-resistant prostate cancer and metastatic castrate-sensitive prostate cancer. It is taken with prednisone, a steroid, to prevent an excess of mineral corticoid effects, and is taken either 1 hour before or 2 hours after meals. So some of the possible side effects can include, but not limited to, high blood pressure, low potassium levels, fatigue, fluid retention, and low blood sugars. Those that may not be good candidates include those who can't tolerate steroids, including brittle diabetics, or those with rapidly progressive disease. And we also have enzalutamide, an androgen receptor inhibitor, which interferes with the connection between androgens and androgen receptors, which can help slow cancer growth. Its indications include metastatic castrate-sensitive and resistant prostate cancer, as well as non-metastatic castration-resistant prostate cancer. Those who would be considered poor candidates would be those with rapidly progressive disease. Some potential side effects include weakness, fatigue, decreased appetite, back, joint, or muscle pain, high blood pressure, constipation and diarrhea, and rarely seizures. So with APIs, the complete inhibition of the androgen receptor activation produces a survival for patients who are candidates for this therapy. Again, it is important that we still maintain a castrate level of testosterone therapy, so men will still need to stay on ADT, whether that is the LHRH agonist or whatever you are taking to keep your testosterone level suppressed. We need to be aware and watching for any additional side effects and personalized therapy for each patient. So as we wrap up, for those of you that have not visited the PCEC webpage, it is really a great resource to men and their loved ones. On the PCEC website, you will find numerous resources, including but not limited to easy to use health event and screening finder tool, where you can simply type in your location and find the nearest free prostate cancer screening and men's health testing events. There is excellent information no matter what stage you are at in your prostate cancer journey. They also have an excellent section on prostate cancer markers, and you can even view past webinar archives like the one today on the site as well. So the website is www.prostateconditions.org. Again, make sure to check it out. I would also welcome you to all check out the Prostate Health Podcast. The podcast was created to better educate men and those who care for them regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions. There's a link to the podcast on the PCEC website. You can also find the podcast on Spotify, Apple Podcasts, YouTube, or wherever you listen to podcasts. Feel free to contact the PCEC team for questions. Reach out and call. Check out the PCEC and Prostate Markers website, and follow PCEC on LinkedIn, Facebook, X, and Instagram. So I appreciate your attention. I know that was a lot to pack in. I want to thank Kara, Renee, and the rest of the PCEC team for inviting me back to speak.